Welcome to a podcast of the American Academy of Orthopedic Manual Physical Therapists. Today's episode is sponsored by the Foundation for Orthopedic Manual Physical Therapy, which is committed to advocating for excellence in FOMPT practice through its funding for initiatives in fellowship training, education, research, and public recognition. The Foundation for Orthopedic Manual Physical Therapy is a 501c3 organization, and all contributions are tax deductible. Donations can be made at our website, aaompt.org/foundation. This podcast series will feature interviews with content experts in manual therapy.
Hi, everyone. My name is Skip Gill, and today I have the distinct pleasure to introduce Dr. Tim Flynn, who is known to many in our community and also outside the community for his long-standing advocacy efforts for the physical therapy profession. Dr. Flynn is a fellow of the American Academy of Orthopedic Manual Physical Therapists, a fellow of the American Physical Therapy Association, and a frequent presenter at state, national, and international meetings. Dr. Flynn is widely published with over 100 peer-reviewed manuscripts on musculoskeletal disorders and chronic spinal pain. He is a professor of physical therapy at South College in Tennessee. Dr. Flynn is also a world-renowned clinician dedicated to providing the highest quality care possible at his clinic Colorado in Motion in Fort Collins, Colorado. His primary clientele includes patients suffering from back pain, chronic spinal pain, failed back surgeries, and chronic pain disorders. He's passionate about ensuring that clients can and should expect better health care and the ability to have fitness and vitality throughout their life. So it's great to have you here with us today, Dr. Flynn. How are you doing?
I'm doing great. And thanks so much for having me, Skip. I really appreciate it.
All right. Well, we're looking forward to this. So I'm going to start out with just kind of an introductory question, which is, your research, your practice, your advocacy at many levels has touched on pretty much all aspects of physical therapy. But I was interested in diving into the topic of low back pain, which is clearly a passion of yours. So was there any particular turning point in your career where you saw low back pain as a unique challenge or opportunity? In other words, can you tell me maybe what sparked your interest in this topic?
Yeah. I think when I reflect back, I learned in the 80s, I definitely went through the school of, manual medicine and did a lot of my background training was in osteopathic school and was very hands-on and in the manual therapy world. And then as I was going through and getting my PhD, this was like 94 to 97, I was in more classic biomechanics, kinesiology, and really looking at bone stress injuries and the things that were more military-related injuries type of thing. But during this time, I was finishing a book on thoracic spine and rib cage topics. It was very manual medicine focused. And I'm finishing my PhD, and basically the ACPAR guidelines come out on low back pain, which basically said anything physical therapy does, or let me restate that, very little physical therapy does has any benefit in the management of low back pain.
Okay.
However,
I remember that.
Yeah. So I was like, oh, okay. However, there was this thing about, hey, but spinal manipulative therapy does. And so, I'm coming out, and that was kind of the beginning of this evidence-based practice. And as you recall, it was very rigid at the time. Everybody would say there's no evidence for this, there's no evidence for that. And it was really this black and white look, even though from the very beginning, clinical expertise was served as a, albeit low level of evidence, was still a level of evidence. But it would basically throw out all the experts and, just let's go with science and let's just beat up all the experts. So
Sure.
that's really what, I came out of in the 90s. So this is now 97. And that's really where I'm like, well, no, I've just seen this has been beneficial. This is something I teach. It's things that I've learned. It's a skill that I don't think we should throw the baby out with the bathwater. And so that's really where my interest started to align. And frankly, I was just fortunate because a confluence of events and people were together at that time, the likes of, Rob Wayner and Julie Fritz, together at Pitt. And, I was down at San Antonio at Army Baylor at the time. And so really it was discussions surrounding that, and then the timing of just passion and research kind of entering together. So that's kind of really where I, from a research perspective, got going.
Yeah, that's great. And you've certainly contributed so much. And luckily, the evidence has definitely progressed. So my next question is, so there is good research now, but, a lot of it indicates that not as many people are accessing a physical therapist as the first line of treatment as we would expect and as the evidence, suggests they should. So why is it that you think that our low back pain patients wind up with these higher risk interventions like injections or surgery before they've really even had a course of physical therapy?
There's more than one reason, but let's be honest, economics is probably the biggest driver. If we go back to the 70s, it was really necessity drove physical therapy into first-line care for musculoskeletal problems in the military post-Vietnam. So really that idea of where PT really became first line of treatment for musculoskeletal disorders was really in the military and the Army system. And that system was driven, is a socialized medicine system. So there really weren't any financial incentives for, that type of care. Just, there's not enough orthopedic surgeons. So you guys got to manage stuff that's not, falling off or is going to, cause, serious harm. So fix it, conservative care first. So I often say, my life's been a bit bipolar. I went from a fully socialized medicine system out to just a fully fee-for-service system. And, and you can make arguments about, good and bad on all systems, but it's just, I think fundamentally when it comes to musculoskeletal care, back pain in particular, big drivers are financials, incentives are not aligned. And we know that that's at the cusp. Even if we go back to the Seattle, the trial on placing low back pain first in the pathway of care, what was that now? It's almost 20 years ago, right?
Yep.
But the healthcare system lost money with that. So it's like, wow, how do we do that? Because we're taking out MRIs, injections, and surgery if we put a PT first pathway. So I think the incentives are not aligned from a system perspective. Once we align incentives, then I think, we're going to have a better opportunity. Number two is clearly the selling of drugs and surgery and injections is effective. Both, you get on an airplane, you still see you can get a little Band-Aid. I love it's been maybe 10 years ago, the little microdiscectomy, and it's in the
Right.
airline newsletter, right? You have, come, we'll fix your back pain, and you just have a Band-Aid there, right? Just incredible marketing and gives you a quick fix and life is happy. And with any pharmaceutical, surgical injection commercial, it's always filled with, butterflies and people dancing through the fields, and life is wonderful. So, let's not, marketing is part of it. So, there's financial, there's marketing, and then the actual individual client, patient, or consumer, if you will, when exposed to PT, they like PT and they believe in PT. And I think the recent focus group the APTA put on did show that patients still, despite all the things out there, trust their primary care physicians and would like them to refer to PT. So I often say it's not just PT first. It's really, if we look at that, I think we got to go back to the marketing directly to primary care physicians to really continue to bulk up that as an entry point, because that's an entry point to many things that have insurance tied to them, must see your primary care person first.
Correct.
So I think in the civilian sector, I think those are the three big categories that draw or that create it.
Yeah. So could I just ask about you? You mentioned some about like the role of imaging, like with MRIs. And I guess how do you approach the patients that come into physical therapy either because they're looking for imaging or they've been referred just because maybe all they've had is some x-rays or an MRI and they've been told by their doc or their provider or by someone else, oh, you got a blown out disc or your back or your discs are degenerated. I guess how do you approach patients in a conversation about that?
Well, it's changed a lot because when I came out of graduate school, right, where you do intellectual jousting for a living, right? So that's, you're taught to just, like beat each other up with facts, and the person that has the most facts wins, right? That's
Right.
when you get pinned. Well, we know facts do not change beliefs or behaviors. So I've definitely toned down that idea. I really hammer on that in the teaching of students so that we create a different mindset of us as we think about imaging and its role in musculoskeletal care. But for an actual patient, that seed's been planted. And it's going to be extremely difficult for me to change it. Now, everyone, I try to find a window in, but that's not what I'm going to launch with. I got to launch with listening, caring, and doing something either with my hands or with movement or with, a discussion point that gets that patient to trust me and that they're in the right place. And then, I think I'll give this joker a try, even though I've failed a bunch of other stuff. This guy's convinced me that, he's worth a try. Okay. So it is salesmanship, right?
Sure.
And it's finding what's the trigger or what is the pathway for that individual patient. And now to stay on that line of thinking, I do want to challenge that belief because not even for this episode, but that's going to be their mindset of how they see their body, and that they see their body as can break, it can blow out, it can degenerate, it can, herniate.
Sure.
So I'm almost doing it more for the long run. And that's why I use things like, wrinkles on the inside. And then I start peppering throughout the sessions. Oh yeah, it's real common. Did you know that? What do you think the likelihood I have a herniated disc is? And now I'm getting older, so I'm in my 60s, I said, and I said, and by the way, I don't have any back pain, so then I started having conversations around that. But the conversations are while we're doing other stuff, right? And that's wonderful. Yeah. And that's what's wonderful about physical therapy, right? Where we can have these conversations while we're exercising, doing some manipulation, doing some type of intervention, but we can also be peppering with some principles and thoughts and keeping it humorous that allows us to teach people that they are robust, that they're not frail, that the medical system can do harm, but you're in the right place and you're the best purveyor of what you need when it comes to musculoskeletal pain.
Yeah, absolutely. And I think part of that is just letting patients know, their prognosis, which for the majority of our patients is very good, but, they may be coming from a frame of mind where that may not be what they've heard from other providers or, again, the talk on the street. So I guess another question follow on to that is maybe for those that are already, heading down less conservative pathway, say they're heading to surgery or something like that, where they think that might be, their only fix, and it might just be, like a one-time fix. I guess, how do you talk to them about maybe a better prognosis and continuing with physical therapy?
Yeah, that's a great question. And I think once the seed's planted, and if someone is really focused on that as an option, in the past, I might try to convince them or talk them out of it. I now kind of shift and say, you know what? The good news is this. If the better shape you're in going into any surgery, the better your outcome's going to be. So if we make you strong, robust, and just a mean fighting machine, you're going to do so well. Some of my patients actually, they do so well, they decide to just delay having the surgery, realize it is, quote, elective, it's their choice. So they just decide to delay it for a while. Some end up not having it. But I don't lead with that. I lead with, you're going to do great if you fully commit to prepping for that. So that they're like, which is true, so that's how I tend to lead.
Yeah. Okay. Well, great. I just I appreciate talking with you about just, having an expert clinician with patients. It's nice for other therapists or other providers to hear how, you approach talking with patients about some of these pretty difficult topics. So I wanted to shift gears a little bit and ask you a question about your experience as an educator. Well, one of the things that I find, which is a fairly challenging situation, within the area of spinal care, is that, we know that using classification systems that will match different types of patients to specific interventions seems to have very good support in the literature. But then on the flip side, some of our manual therapy approaches and teaching methodologies reinforce specific and sometimes very difficult psychomotor skills that we're trying to spend a lot of time with students trying to build their expertise. So, there's a little bit of a dichotomy there. How do you talk to students about, still the need to build expertise and, hands-on psychomotor skills, with high precision when they also have to really consider just the broad management approaches?
Yeah, I think that's an excellent question, and one I probably contribute to confusion. I hope I do less of now. And I realize a lot of the challenge goes around language.
Uh-huh.
And so the language we're using around, say, a given technique, and our belief system in terms of what we think we're moving or modulating, and the mechanisms that we believe we're trying to interact. And I think what happens is people confuse mechanisms with mechanical descriptions, with terms like precision, general versus specific. Like no one's really ever defined that term, like a general lumbar manipulation versus a specific. I would argue every spinal manipulation, if we're using that technique, should be highly specific. I want my surgeon to be highly specific. That, there are some arteries there that I might lose my leg. Right. I'm just saying, I want you to be the most highly skilled and specific surgeon that you can be. And that means you need to practice your butt off over and over to do that. Now, I think in physical therapy, the vast majority of what we do is so low risk that I think sometimes people have used that as a recipe for being mediocre. Yet the best of any field does not have a lot of skills, but they have highly honed the skills they have. You can look at
point. Yep.
Yeah, let's look at baseball. Let's look at a hitter that may actually break the home run, actually has broke the home run single season Yankees record, right? I mean, It's the same thing. Now, granted, you might say there's a curveball, fastball, there's different variables, but how many times does he practice that swing over and over and over to become highly specific about what he's doing, knowing that sometimes it might miss completely, or you might just foul it off, meaning you're at L2 when you're aiming for L4. But man, if you're not even trying to be at L4, you just well be up in the clavicle, right? I mean,
yeah, good point.
So I just think it's kind of one of those we've created in education and research, I think, ways to debate things that I think are a bit meaningless. No matter if you're teaching someone to do a quad set or a static leg raise, I want the precision of that to be just as good as the precision of anything else we do. And that's truly a professional, right? And I think that's where the argument gets a little off, because what we're saying is manipulation works for a good majority of patients with acute spinal pain and chronic spinal pain. And we do know that it's a component of the package of care. But boy, I sure want to go to the person that does it the best. And I think most of us would rather have the dentist that has soft, caring hands versus the one that basically tries to tear your jaw off when they're getting their finger in there. But that's just me personally.
I think we would all agree. I guess if I can follow on too with, in terms of dosing, always seems to be a challenge for many practitioners. And I kind of wanted your thoughts on this, because finding the right balance is critical. If you overtreat someone, then you wind up risking the aggravation of the patient. Or if you undertreat them, you just might be ineffective and miss any type of therapeutic benefit. Could you speak a little bit about maybe how you try to guide therapists, whether in the clinic or students, in trying to determine the appropriate amount of dosing, not only for your general physical therapy interventions, but even more so when it comes down to manual therapy?
Yeah, that's a very good question. And it's I think one that we don't have really solid answers, but I do feel like we're getting better with that. And I think the model of, whether it's attributed to Maitland or others, this idea of test and retest, the idea that for a lot of patients, you can find an impairment of motion or of quote unquote stiffness or discomfort in a certain movement. And we can then do some intervention. And then we can retest the response to that and literally show the patient whether they're better, worse, or there's really no change in that movement pattern. And I think if that's just deeply embedded in our psyche, patients see it, well, let's just keep doing some more of that because it's going in the right direction. Now, at times, you're just hitting home runs and you probably, went a little too far. But, if you've been showing them along the way, they actually realize, well, yeah, I was kind of with it too, because I was seeing a lot of improvement. And you just said, man, my system wasn't quite ready to take that much input. But actually, that aggravation it was kind of demonstrated, right? Because the patient was part of the process, seeing like, oh, I'm getting, more you do that, the better this feels. And often saying that, it's kind of like, we ran a marathon today and I don't think you've ran a marathon in a while. So a little bit of like, hey, feeling like I've been hit by a bit of a truck is okay, but I'm going to keep moving through that. And again, it depends on the patient, but frame what their expectation, if they're going to be a bit sore from the activity, if you feel like you've overdosed it. I think the bigger problem, though, is on the underdosing. I think definitely.
And I agree.
Yeah. I think that's been the challenge, especially with older adults. We often think that they're frail and we have ageism. We have bias against our older adult population and we underdose them when these are robust people that have lived a life and seen hard times, and we're, not dosing them enough to get them to show change. And those to me are the ones that are the easiest to show change within session. I mean, and to get buy-in to say, this is what hands-on care and followed up with some movements, you can do. You don't have to be like this. This isn't called aging. This is called sitting too much, living our lifestyle.
Yeah. So it sounds like to a certain extent, it's less of really a prescriptive type dosing, in that more that you're involving the patient, you're, using clinical reasoning skills in terms of a test retest. So you're adjusting the dosage kind of as you go and as you've proven it to either be beneficial or maybe too much.
Correct. And I think thanks, you summarized it way better than I did. So and I do think this is a fun area of research and developing, I guess, model of reasoning to determine, I see a dashboard almost of, again, underdosing, correct dosing, overdosing. And, how do we get in that spectrum?
Yeah. How do we navigate that? Great. Well, so I thought maybe what I'd like to ask you to do is, because I thought it might be helpful for our listeners, maybe just to hear about a typical course of management for someone who might come into your clinic with, say, acute low back pain. Do you have like an example patient in mind, or just kind of a think through, your typical patient coming in? And could you talk to us a little bit about just how you progress both the examination and the treatment of that patient over maybe an initial course of, say, 4 to 6 visits?
Yeah, I think, again, as we get into practice, and one that I'm in clinic less, and because of that, the type of patients I see are typically more on the chronic end and have been referred to me from other therapists. So often, or they hear about me and come in that way. And so I'm often seeing folks that have seen therapists and have failed therapy previously. So if we take that patient, so maybe the typical patient with, on and off back pain for the last 3 years, episodic in nature, typically when it happens, initially it was only a couple days, and now it's lasting for longer periods of time.
Right.
And, it's really affecting their life. They quit, golfing. They've quit doing things they like to do because of their back problem. They've, seen the surgeon. They have some changes. Typically, I see folks that have either had surgery or they said, well, I want to avoid it, and this is my last ditch effort. Most of the ones I've seen have seen some type of a surgeon. First and foremost, I try to, listen to their story and then establish. I often will apologize, depending on what their story is, to where the system has really not helped them along the way. So to just kind of create it's okay to be frustrated, because I'm just as frustrated as you, how the system you've gone down this path. And at that point, though, I really try to say, okay, here's what we can do today. Today, let's try to establish, is there how you respond to a few interventions. I do a quick lower quarter screen to mainly on these patients to show that, the good news is the vast majority have no neurological deficit whatsoever, but it's therapeutic in nature. And sometimes people say, wow, that's the first time somebody's checked my reflexes and, regarding my back pain. I'm like, whoa, okay.
Which is concerning to begin with.
Yes, exactly. So part of it is that therapeutic exam and doing a detailed screening exam, and then establishing, we should be able to make some changes within session. Even if they have, a lot of pain behaviors and a lot of persistent pain symptoms, a lot of widespread pain, I still say, underlyingly, there's mechanical input. Let's see if we can find some things.
So when you say within session, you're saying to be able to treat them that same day and show some effect?
Absolutely. I would like, so if I see someone that seems to be quite irritable, meaning, during standing, they're bending forward back and they have no real preference, but they're pretty uncomfortable each way, I might not touch their back at all on that first session, but, I'm going to say, you're a movement system. Clearly, it hurts with these movements. Let's do a little work here, and then let's stand up and do this again. Well, what that little work will be is, I'll manipulate the thoracic spine, have them do some deep breathing, get their ribs moving. I'll do probably some traction to the hips. I'll choose a side based on, a Faber test or something to see which side's stiffer, or maybe both. So some traction, maybe manipulation to their hips. Okay, and then I'll get them back up again, and let's have you retest. And most patients will have a change in their movement. And at that point, I pause. I say, you're seeing this as a back problem. I see it as a musculoskeletal system problem. All the parts are not doing their job anymore in a nice, effective, robust way. So you're pretty irritable in that back. So why don't we start by getting the rest of the system super healthy? And we're going to do that, like we did today, but now let's get you on some exercise geared at there. And almost all of those, it's going to be breathing. I'm going to teach them to actually get their diaphragm to actually drop down and the rib cage to open up. So that'd be kind of a day one thing where I might not even palpate their lumbar spine. And it's kind of intentional. Again, I've painted that picture of someone that's more chronic. The answer doesn't lie just at this L5 disc that you have that's herniated. It's way bigger than this. It's a system problem. So, and that's probably, based on, research showing more system level treatment, but also just I grew up more in the osteopathic model of you treat the musculoskeletal system. You don't treat, just the thing that's hurting at the time, and I think that's where medicine has gone wrong. And we see that across all systems, cardiovascular system, right? It's just, we'll clean out the arteries. Well, no, this is a disease of the entire vascular system due to lifestyle primarily thing. So we got to treat the system, not just clean that one part out.
Yeah, that's a great point. And then, so kind of following that day one, maybe how often would you be able to see a patient like this, and what might sort of the end stage of those last couple visits, what might you focus on?
Well, I'd also try to, during that visit, say, can I at least see you weekly for the next 3 weeks? I really feel like we are in this together, and I'm not the savior here. We need to kind of figure this out together. Try to get them to commit that, no, you got to see me, and then each time we're going to progressively going more into, your chief complaint region as you begin to understand what we're after. So, and again, I do a lot of manual therapy, but my manual therapy is do a lot of thoracic spine and rib cage with the idea of getting them to breathe better, to really realize, okay, ultimately I got to get control over my respiration. I need to get control over, how I'm feeling. And I'll probably pepper them with some, maybe an app, a breathing app or something. After that, I do, direct manual interventions to that area. I might do things like trigger point dry needling. I might do some instrumented soft tissue work around. Often it's a lower rib cage because they're not able to expand, and treat the impairments that I feel are driving their system, but rapidly get him into just functional weight bearing stuff. Just a good old squat. And showing them, okay, this is going to be our test retest. Let's see how you're doing through that, and start loading their spine quickly to show them, to get them stronger, but also show them that they're robust. You're not frail. This spine can tolerate these loads. We just need to do it in a systematic way, and do it with me, so we can listen, we can with each other and problem solve as we go through. And then as we progress, I think it goes back to where I fail sometimes is we know that flare-ups occur, and I am now much more aggressive in saying, okay, boom, you're doing well, but you're going to come back in 2 weeks. And then, okay, if you do okay, again, this is going on for 3 years, right? So I'm not going to turn you loose. You need to, right. I'm going to work you through that. And then once, patient's out, I see him in 3 months. That patient's mine for life. I'm more of a dental model. I treat their musculoskeletal system. I want to see you in 6 months, or I want to see you, beginning of next year, and you come in for visit. There's always a tune-up needed. And I think this goes to some of the other research that when we look at a lot of the osteoarthritis research, not giving boosters, everybody, in the dental world, I get so many texts and emails from my dental provider about getting in for my well check.
Correct. Yeah.
And, again, and that's good. They're trying to maintain, we know, the importance of oral health to overall health, so I think it goes back to some of these other discussions we've had about once we engage with the patient like that, they should be you should be their therapist for life. That doesn't mean over-treating them, but that means seeing them every year at a minimum, doing some booster sessions with them, and say, okay, you're doing great there. Well, we'll progress you then. Let's try this. What gives you joy? Why haven't you been doing that? You haven't been running? You can run again. I have patients that quit running. I'm like, no. I mean, we can run again. That's, running is a normal part of living, and I always get such joy when I have my 80-year-olds start to run again. And it's very different. They're light on their feet. I teach them to be, very light and bounce and whatnot, but it's giving them joy to the fun of movement again.
Oh, that's awesome. That's a great perspective to have. And certainly, I mean, I think we do need to be, there for patients for the long term, and also for, if they need to get in for a tune-up or something like that. It's, I mean, similar, lots of analogies, but similar to our, patient with diabetes. You don't say, oh, well, you got your blood sugar under control, so, you don't need to come back and see me.
Yeah.
You know, those things are going to, especially with musculoskeletal, those things will flare up. So if they know that they've got access to you to get back on track for that encouragement or that treatment, then that's a great model to use.
And I would just add one thing, that when they come in, I'm actually treating them for other things as well, such as their diabetes or, other age-related things. And, say, well, exercise is one of the biggest drugs on the planet. So, I'm very open about saying, no, we need to, don't tell me just about your ache and pain. Tell me about your overall system, and what are we doing? How can we provide support to you to just be a healthier human? And we have so much to offer as physical therapists. And I have to say, it's us holding back. These conversations, I get calls asking about all types of healthcare things. And again, I'm not an expert on these things, but my job is to point them and help steer them in the right direction and provide them some guidance and, help them navigate this complex system.
Yeah, absolutely. Well, listen, I've just enjoyed this conversation with you today. It was nice just to get your perspectives, both as a researcher, as an educator, as a clinician. So really grateful for your time. If there's maybe one thing that you'd like our listeners to remember most, a take-home point about, treating low back pain, I guess maybe what would that be?
I guess I would leave you with, let's continue to fight the medicalization of a problem such as low back pain, and to, move it and move on. That the fact is, we get people moving, we get them into programs that make them more robust, and let's instill confidence in their health, and that let that low back pain be just almost a positive thing to say, man, this is how we connected with you, and you're going to be younger next year. Let's now that we got this taken care of, let's move on to the next thing. Let's get you stronger and more robust and have more fun in life. Use it more as it's a positive thing that they stumbled in to see you, and now you can be on a journey of health together with that person.
Oh, that's great. That's a great perspective to leave us with. And again, thank you so much for joining us for this particular show. And what a great opportunity this has been.
Well, thanks again for having me on this, Skip. And thanks for all you guys do, and particularly for the foundation and how ultimately we can make a difference for the lives of those folks we come in contact with.
Absolutely. Okay, thank you very much.
This has been a production by the Foundation for Orthopedic Manual Physical Therapy in support of AAOMPT. You can learn more about the Foundation for OMPT, as well as make tax-deductible donations on our website at aaoMPT.org/foundation. The views and opinions expressed on this podcast do not represent the official positions of the Foundation or AAOMPT. The information provided should not be used for personal health care or clinical expert advice.